Great, thanks, Carolyn. Hi, everyone. I'm Vidya. I'm a volunteer with Fertility Matters Canada. All week long, we're bringing you informative content from professionals in the field to talk about topics that are highly relevant to your fertility journey. So as you know, Fertility Matters is a not-for-profit organization. We rely very heavily on donations from the public and from professional organizations. And we're very thankful to today's sponsor, Ferring Canada. I'm excited to be with you here today with Dr. Tom Hannam, who's the founder and medical director of Hannam Fertility Centre in Toronto, and Alex Lagunov, I hope I'm pronouncing your name right, Alex, is the laboratory director of CCRM Toronto and Hannam Fertility. We're here today to talk about embryo health and safety in the time of COVID-19. And we're taking your questions live, so please feel free to chime in on Facebook with your questions, and we'll get to as many as we can. So Dr. Hannam and Alex, would you like to start us off by just talking about what's been happening in the last couple of weeks with respect to fertility treatments and what the embryos are doing right now?
Yeah, I'd be happy to start with that. It's been a very difficult time for everybody. As everybody who's going to be coming into Facebook Live will be well aware of, the fertility clinics across Toronto, across Ontario, across Canada are closed to active services. There's a couple of reasons for that. One was as part of a public health's mandate for social distancing, and then a second reason is trying to be protective of PPE. The idea being that if we in the fertility community use up a lot of PPE, that is things that could be perhaps used elsewhere. And so while everyone was trying to get on top of the data, it was thought that the wiser course of action would be to pause. Been a difficult decision all around, I would say, and there's lots of debate about exactly how it is, and most importantly, when it is that we'll be able to reopen to services. Now, in the meantime, we're still taking care of people's embryos. And interested in answering any specific questions that people might have today, but Alex, I was hoping to start just by asking a couple questions of you. And the community, you should know that as a medical director, I'm in charge of the lab, but I'm actually not day-to-day running the lab. It's the IVF laboratory director who does that. And so fundamentally, Alex, you're the person who's responsible for taking care of our embryos.
That's right. That's right. Thanks, Tom. So just speaking on safety related to embryos, as Dr. Hannam said, this has been a good pause for all of us, I think. And it's given us time to assess the safety and just the situation in Canada and how this virus has been affecting many people, of course, in Canada. I'll talk about two aspects of safety. I think one being just safety of your embryos here with us, as they are cryopreserved, and then just generally the safety of us as we resume at some point resume operations, and how if there are any implications on.
Alex, can we start with that then? Just talk about the embryos themselves. People have been often writing in with specific questions and worries about that. It's not something I've related to. I've never questioned that. Can you provide some
embryos in storage, you mean, right?
Yeah, like I'm not sure why people were worried, but I know they have been.
So there could be, I think there could be a couple of different aspects of that. So I think one aspect is as patients obviously learn that clinics have been put on pause or stopping any active patients or starting new patients, I believe, as a patient, you'd be concerned, how are my embryos safe in these clinics that are now perhaps laying personnel off, and is someone going to be there to take care of my embryos to make sure that they are safe? And safe by safety, I really mean that when they're cryopreserved, as you know, they're stored in these large vessels. The vessels require liquid nitrogen to be continuously topped up in order for them to be safe. So I can tell you that from the Canadian landscape, we have the CFAS, Canadian Fertility and Andrology Society, that's been very, very active throughout this whole time, ever since we've gotten direction to pause treatment. And they've released guidelines as to what they recommend for all clinics to do, and it's to ensure that their staff, clinic staff, is available to continue to top up these dealers and monitor alarms.
So how often do you actually come in? Like, are you in once a week?
We're here daily. We're here daily, as if we were open, essentially, which we are in the lab. And there's several checks that we have to perform according to our guidelines. So we are certified by CAP and Accreditation Canada. Here at CCRM Toronto, and CAP is a College of American Pathologists. It's an independent body that inspects reproductive labs in North America. CAP actually puts forth a pretty extensive set of guidelines for various aspects of lab. Cryopreservation is a main point for them, and we have to adhere to their guidelines, independent of times, whether COVID is here or not.
I see. So COVID or not, so you're doing it by guidelines. You're doing a daily check.
Exactly. So the first thing.
Can you tell us what the what do you mean by topping up of nitrogen levels? What does that mean?
So great question. So what the tanks require is that over time liquid nitrogen, because it's so cold, it's negative 196 Celsius, right? So it's very cold, and although the dewars are very heavily insulated, there is some slight evaporation that occurs over time. So these dewars need to be topped up weekly. Depending on manufacturing instructions, some of them more than that, more frequent than that. So what we need to make sure, and as this was all unfolding, the first calls were actually made to our distribution of medical gases and liquid nitrogen. So we had reached out to these companies, and we have a safety system where if one company is not reliable, we can switch over to another. There are several here available in Ontario, but I'd spoken to the owner of that company as soon as we heard rumblings of closures, to ensure that their supply chain will not be interrupted, and they reassured.
Okay, so yeah, let's talk to that a little bit. So the supply chain in fertility is complicated, and all of us in our personal lives are well aware of what it's like to go to a food store, and we're all reading the news. We know that supplies of different things are difficult. The joke about toilet paper. So let's talk about on the clinic. Here in the clinic, we're aware too that some medical supplies are difficult to come by. PPE is one, which is why Ontario now has a central registry for all fertility clinics, all freestanding clinics and hospitals to participate in, so that everybody knows exactly how much PPE is around. And yet, the worry would always be that something in the supply chain is more difficult to access. Not necessarily here in your lab, are you aware of anywhere where that's been a problem for labs?
Not yet. So again, through CFAS, we've put together a working group of all lab directors in Canada, and we have weekly calls where we discuss various issues related to the shutdowns, related to COVID, of course. So that's been very, very helpful, and we've discussed the supply chain potential issue of having obstacles in that realm, and none of the lab directors that were on those calls have expressed any concerns at the moment. Everyone's had smooth distributions with liquid nitrogen. They've been able to do their top-ups regularly. They have their alarm touch points with their staff. They're regularly checked and so on. So
okay.
The other things, of course, as we get closer to some of these clinics reopening, the true test next will be to make sure that plasticware, culture media for embryos and such will be able to get through these channels smoothly. Here on premises, we being a part of a network helps us a little bit, where we can leverage the power of the network, and through the CCRM network can hopefully get these things if there's any issues.
Okay, so you're feeling good about supply chain for keeping embryos safe. You've got somebody there every day. You happen to be on site today. Alex, what if you get sick?
So, moving forward, of course, right now it's we don't have any active patients in the lab, but as we open, the network has been great in CFAS. I'm sure will be as well, of setting forth guidelines of how to operate safely, and I think to do so, it sounds like it will be through groups and groups of people, where you have two teams essentially that operate on different days, and they don't overlap. And if someone gets ill, then that one group will have to be put on hold.
Takes the team out for a little bit, right?
Exactly. Yep.
What we're going to benefit from, like all of society is going to benefit from, is going to be rapid access to testing for asymptomatic people, so that even those who are asymptomatic have the opportunity to get regularly tested for viral testing or antibody testing. It's going to be important, not just for our clinic, not just for the fertility space, but for Canadians. It's just going to be inefficient until then, and so I'm agreeing with you that we're going to be doing that on the clinic side as well, just so that we can always, so that once we're reopened services, we can maintain that.
That's right. I think with testing, we all hear things changing daily or even weekly, and in a positive direction. I think there's more and more companies that are coming out with readily available tests that are really, some of them are just plug and play, that don't require a geneticist on staff, of course, and those units actually happen to be pretty precise, or very precise. So it sounds very promising as well. I was speaking to our corporate lab director yesterday. We're in the CCRM network, and it sounds like there's a lot of positive news in the States as well, related to testing and availability. So it's coming. It's all just a matter of time.
So Alex, can we speak a little bit to the health, and then Vidya, if you want to cut us off because we're boring, then please do so.
I just want to ask a question. This is all fascinating. Go ahead, Tom. I'll go after.
Okay, because the next question I was leading up to, really on behalf of patients, Alex, was about this COVID virus and the health of embryos. So when we closed down, when Canada closed down, the reality was the percentage of the population that actually had the virus wasn't very high at the time. I know we're all struggling to know what that percentage is, but today, probably in the highest density areas, it's as high as 5% of the population. You know that I can't know that. I'm not an epidemiologist. None of us know for sure, but still, most of us have not yet been exposed. So the argument would be that most of the embryos that you would have cryopreserved, Alex, similarly did not come from exposed people. But let's go forwards. That's presumably, now we're going to do our best. I've got my temperature gun. We're going to be doing all kinds of swabs in the end, all kinds of stuff that we'll be doing. But let's do a worst case scenario. A patient comes through and they are infected, and we're doing an egg retrieval for them. Do you perceive two things? Do you perceive that that's going to affect the health of the embryos for that individual? And then secondly, do you think that anyone else needs to be concerned?
Great question. So I think, first of all, I think it's important for everyone that's dialed in today to understand that our embryology labs are already operating under some of the most cleanest conditions and protocol, right? So we already wear all the PPE, even before all these times. We already do rigorous cleaning and quality control of any potential source of contamination. We actually, our clinic, and maybe not all clinics in Canada, but our clinic is equipped to work with viral patients. We do have several protocols in place, from the time of retrieval to embryo culture to storage. You've got your own air system in the lab that's independent from the rest of the building. Exactly. So that's another great example. So we have an extensive filtration system in all the labs that provide positive pressure that will filter the air 15 times within the hour. So it's. But what if a patient, which is all good, but what if a patient is actually unwell as I'll go through my worst case. Again, this has never happened. I'm just talking it through. The patient has a retrieval. She actively has the virus in that moment. Right. So going by what I know personally and what I've read up, and I think we've all been doing a lot of reading about this virus lately. Yeah. So within our field, for example, we don't know that the virus can get through to the reproductive organs. We know there are receptors, these ACE2 receptors, as I'm sure you've heard, found on the reproductive organs, but it doesn't necessarily mean that the virus can be present there. I've read numerous research papers, and there's been a lot of literature published lately on this virus. I think there's a fast track button or something. There's just lots and lots of papers, and they're coming out daily now. But from everything I've read so far on the male and the female side, there's no signs of the virus being found in either the sperm or the follicular tissue, or which is so different to too early, right? So it is. What I've heard, so go ahead. Sorry, Tom. Yep. Oh, I'm cutting you off. I was going to say it's just so different to Zika, where we were aware very quickly. Exactly. The other thing is what I know about hepatitis, the different virus, of course, but we know that there's been they've failed to detect sequences of the virus in culture media and vitrification media and liquid nitrogen. So patients that have come through the clinics that are actively positive or positive for hepatitis C or B have not been tested positive, or sorry, their media of embryos being cultured in has not been tested positive. So we, again, assuming that a similar route is happening here, there's a good reason to think that there may not be any virus found in embryo culture media and onwards throughout the embryology lab.
Well, this is consistent with what we know of pregnancy as well. Again, this is information that's valid today, right? We're all going to be finding out information as it goes forward, but from what we know today, pregnancy itself seems to be uncompromised to the degree that none of us want a person who is pregnant to actually get this SARS-CoV virus, but the development of the baby seems unaffected, which is consistent with what you were saying, Alex. I'm really not trying to get too inside baseball here, but when Alex was talking about ACE receptors, our understanding of this virus is that it sticks onto receptors called these ACE2 receptors. So wherever in your body you have more of those receptors, you're more likely to see symptoms. So for example, there's a lot of these receptors in the lungs, which is why this condition will routinely present, as we're all well aware of, as this dry hacking cough, because it's affecting their lungs. These receptors are in the brain. That's why people are often reporting a sense of a loss of smell and a loss of taste. These receptors are in the kidneys, in the renal system. And there are receptors in the testes and ovaries, but it doesn't seem to be the virus doesn't seem to be present in follicular fluid, for example, the fluid that is ultimately surrounding the eggs. We're in a privileged position to be able to read a number of papers that are coming out prior to publication, and there are definitely concerns around sperm quality just after an infection, which is not a surprise, everybody, because we've known for a long time that after a significant fever event, after a significant viral infection, sperm counts will drop for 3 months before recovering, is the expectation. So the early data showing lower sperm counts is not a surprise. Vidya, we've been doing all the talking. I'm not sure if there's been any questions from the community. I know with these Facebook Live, there's more people who see them afterwards than in real time. But is there anything that we haven't covered that you think would be relevant to anyone watching right now?
Absolutely. So just to summarize, what we're hearing is that the embryos are safe. People are watching them. There's no evidence yet that the virus is actually affecting or can actually affect embryos. That's
Correct.
all we know as of today. The questions that we're getting in, of course, are the questions that you can expect to be getting in, which is, when are the clinics going to open up?
Right. So when are the clinics going to open up? So what we're responding to is two different pressures. So one pressure that we're responding to is from public health. My expectation is that different provinces are going to open up at different times, just as they are around the US. So let's take the US, just a bigger population. It's easier to see what's happening. Look, we all know the US is a bit of a gong show when it comes at a public health level for taking care of COVID, but the fertility community has been really good. The ASRM, just like the CFRS, the guiding body suggested that clinics don't open. Now, on a state-by-state basis, different clinics are doing different things. So for example, in New York State, Governor Cuomo put out a piece of paper saying that it was considered a technical update, that fertility care was an essential service, just like access to other reproductive rights. So that women should have the opportunity to access the birth control pill, long-term birth control options, access to abortion, access to fertility care, access to OB-GYN, cancer screening, endometriosis care. It's self-evident. Women's health care is an essential service, but they chose to actually spell it out. And in doing so, more clinics took from that confidence that it was actually appropriate to open in that environment. I think the same thing is going to happen in Canada as we get increasing amounts of clarity from our provincial bodies as to the safety within that community of opening. That's going to provide greater guidance for individual clinics to make decisions and for the CFAS as a whole. There's a second issue, of course, and that's access to PPE. It may well be appropriate for a fertility clinic to be operating for the sake of an individual patient. But as a society, we can all agree that there are a lot of different kinds of essential services, and it could be very difficult for anyone to have visibility onto what's the most essential. So if I'm struggling to help a patient be able to freeze her eggs, and a dentist really wants to help remove somebody's tooth who's impacted, and somebody else is not able to have surgery despite needing heart valve replacements, who's to say how we should be getting through that as a society? Now, the good news here as well is Ontario has set up a registry so that every fertility clinic in Ontario now, on a daily basis, updates to the registry what our PPE levels are. So what I'm taking from that is there's now visibility at a level higher than I can see as an individual clinic, because I don't want to be responsible for opening up and compromising someone else's care that really needs it by the province having visibility to all the PPP at all the hospitals, all the centers, not just the fertility community. It's more likely that we'll be able to work confidently that we're doing the right thing. All right, so what a long answer that was. It's going to be soon, you guys, but I don't know of any clinic that's opening today.
Do you think, one of the questions is around a vaccination for COVID-19. Do you think it's something where we have to wait until a vaccination is widely available, or do you think clinics will be open before that?
Yeah, we're going to be opening before that. There's absolutely nobody thinks that clinics should be closed for 18 months. It's well recognized that that would be inappropriate. An essential argument from the beginning was that while fertility is a time-related condition, it's a real disease. It would be encompassed by essential services. It's also recognized that for most patients, it's not as time sensitive as, say, having access to an abortion would be. Now, that's not true for all patients. For example, people with cancer, for them, days and weeks can matter, and they've been able to access care throughout this time. Still, increasingly, as the weeks go by, as the months go by, more and more patients will get caught up in that. I think we could make an argument already that somebody who has already been asked to wait a month or two, if they now are in the unfortunate space to actually catch the disease and needed to recuperate from that, suddenly these timelines get very serious very quickly, which is why I know a lot of clinics are working together to work with the CFAS to put some clear guidelines in place so that we can quickly do this, but also do this in a manner that is safe for patients, safe for the embryos, and safe for our staff. It's going to be really important that it's appropriate when we reopen. But no, it's not going to be about waiting for a vaccine. It's going to be about waiting for clinics to be able to offer this service safely.
So do you think, I know when you did your last Facebook Live with us, you talked a bit about doing retrievals now or whenever we open up again, and then waiting a bit for frozen embryo transfers. Is that what you foresee as kind of how things will open up again?
It's a great question. So let's look at the US. Different places have done different things. Boston IVF is the group that's most closely associated with Harvard. They are focusing entirely on embryo transfers and IUIs, helping people achieve pregnancy right now. The argument in favor of doing that is that all the obstetrical societies in Canada, the US, around the world are still actually in support of pregnancy. There is no subtext to that. There's no encouraging people to have abortions or anything worrying like that. And I mention that because it certainly was the case when it came to Zika. I'm not going to minimize the impact of being pregnant on the healthcare system right now, but not all the obstetrical societies are aligned with the idea that it's okay to get pregnant. So by extension, Boston IVF is doing just that. On the other hand, CCRM New York is first focusing on egg and embryo freezing. Their intent was to help people cryopreserve during this moment so that they didn't have to get pregnant right now. They could freeze their fertility in time and just wait this out. It may well be medically acceptable to get pregnant, but I think a lot of us are hoping to avoid going into into physicians' offices if we don't actually have to. And so when you ask me what's going to open first, I really think it's going to be on a clinic by clinic and jurisdiction by jurisdiction level. There's different services that clinics provide, from getting pregnant at home with home monitoring to inseminations, IVF retrievals, frozen embryo transfers, early pregnancy programs. I suspect a lot of us are going to be opening up in stages.
Great. We have a great question here about importing donor sperm. Do you foresee any challenges with having access to even donor eggs or donor sperm that are coming from outside of Canada?
Yeah, thank you for that question. So it's a border question. Canada has always interacted mostly with the US, a little bit with Europe, in moving donor sperm back and forth. We have our clinic has a lot of experience with this because we do work with CCRM, which is based out of Denver. So Alex, it's actually a good question for you. Have you seen any problems with shipping materials back and forth?
Early on, as clinics were pausing, we did experience some obstacles with companies just not offering that service at the moment.
Can you talk about that? Like what would happen?
So they were just not able to ship. That's the only obstacle. They weren't able to deliver, and because everyone was trying to learn and how to be open during these times, kind of like what the clinics are. And so as we move forward now, with the right amount of PPE, and that was the only obstacle. There was no increased risk. There was no issue at the border. So we've been actually shipping our biopsies to Denver long after we had stopped doing new cycles, and we would check in with them on a daily basis to ensure that the borders are not giving them any hard times, and they've been smooth actually. So
so Alex, just to be clear, then you're saying the borders haven't been a problem, but it was the human interfaces at either side that were. So I see. Yep. This specific question was about donor sperm. Do you think, and I recognize it's speculative, but do you think there's going to be any troubles bringing sperm from, say, Zytex, one of the larger U.S. suppliers, up to a Canadian clinic?
There shouldn't be. Not that I'm aware of. There shouldn't be.
Okay. All right.
Great. Just to recap, I think you already talked about this, but is the decision to open up again, will that be a clinic by clinic decision or Canadian-wide decision?
Yeah, no, ultimately it's clinic by clinic. In fact, ultimately it's it's clinic by clinic. Ultimately in Canada, care is still recognized to be between the physician and their patient. The regulatory bodies, of course, public health, the local colleges, but things like the CFAS and ASRM that we've been referring to, those are societies. There's no regulatory heft behind what they say. They're just providing what they believe is guidance for best practices.
Great. So it sounds like we're going to be waiting for a little bit longer before we can access treatments. What can fertility patients be doing in the meantime to optimize their chances?
So I think it's reasonable to be considering timelines in weeks, not chunks of, not quarters or 6 or 18 months. I think we're talking about weeks. So I think it actually is appropriate at home now to be thinking about what it's going to be like when the service does become available. Not everyone's going to agree with what I'm going to say now, but I don't think physicians are particularly I don't think we are particularly focused on vitamins and lifestyle choices that people can make. So we work really closely with A to Z Wellness, but across Ontario or across this country, there's all kinds of really strong naturopathy teams who are going to be able to help people do work on lifestyle optimization. Gosh, isn't it hard, you guys? Like, we all know we're all at home, or many of us are, and so of course we should be exercising more than ever, right? Is anyone actually doing that? Are we actually eating better? I don't know. I know we should be. It's hard. It's harder than ever. And yet these small steps that you can make would make a big difference. And like everything in life, I think coaching makes a huge difference. So if you can find a caregiver that would be able to provide personal guidance for you and lifestyle choices for you that would make a difference for you, then I would suggest that this is a good time to be doing it, because these weeks now will ultimately lead to the quality of the eggs and sperm, or your endometrial lining when your opportunity for actual care comes up.
Right. When clinics open up, do you think there will be a heavier wait time once the services are available again?
Yes, I do. I think that the way clinics had operated prior to March 15th won't be seen again for a long time. So any active patient will be well aware of what it would be like to come to a clinic at 7 or 7:30 at 8 in the morning and having a bazillion people around. It was very efficient. It would help a lot of people get in and get back out and get to work or whatever they need to do with their lives. And it was all predicated on there being no social distancing. Now that we're going to be all integrating social distancing, there's going to be far fewer people at our clinic, at every clinic, and they're going to be spread throughout the day. Ultimately, that's going to lead to a limitation in the number of people that can be cared for at any given moment. Secondly, I think that the clinics are going to want to be very careful. They're going to want to make sure that the staff is protected as well. And to be able to do that, we're going to need to really limit the number of people that come through an organization on any given day. I suspect what most clinics are going to do is carefully roll out services. They might choose, for example, patients that they feel are the most time sensitive and then build from there. So I don't want to speak for other organizations. Everyone's going to have to do it differently, but those are the pressures that clinics will be looking at, absolutely.
So how do you get on that list?
Yeah, right? Yeah, exactly. How does one be the most important? You know, it's always serious business when we're trying to regulate access to care, and that's going to come down to, again, the specific relationship you have with your specific doctor, and so I won't be able to speak for it across the country, but I can say that. Just as you asked, it's a very reasonable time to be focusing on lifestyle. It's not unreasonable to be starting to ask doctorate questions of your clinical team about what they can imagine timelines might be like and what they could imagine you as an individual, when you as an individual might be able to access care.
Great. I'm not sure you'll know the answer to this, but will the provincial funded cycle, so the Ontario fertility program, will it be impacted by this wait time that you just mentioned?
Yeah, it's a great question. So I'm in contact with the ministry, with the OFP, the Ontario Funding Program. Is that what it's short for? Anyways, so they are the program is as robust as ever. The way it works is the funding starts every April 1st. We're not even out of April yet, and it's going to last until March 31st. So that funding is all there. If you've been promised access to funded services within this fiscal year, within the government's fiscal year starting April 1st, I would have every confidence for you that you would still have access to that care.
Great. For women who do find themselves pregnant at this time, you know, there's those limitations to healthcare to a certain extent right now. What are your suggestions on what people should do? For instance, if you have low progesterone and you know that's to be an issue and you find yourself pregnant, how do you access that progesterone? How do you get the care you need in this early pregnancy time?
I think there's two aspects of care. One is the direct medical care that we would all like to be able to provide people, like access to progesterone. The other aspect of care is the emotional supports that all of us need when our lives are going through such extraordinary changes. So let me be frank. I think the emotional supports are much more difficult. I mean, I can't tell you how happy it makes me to come into the clinic as I am today and actually see live human beings again. It's just, it's something else. I know everyone's 12 feet away and we're all going to be wearing masks and all that, but just to see people again. Without being able to actually see somebody, the emotional connection just isn't there. So I'm just going to acknowledge that. That's a tricky part of first trimester care. But the medical part, it should be straightforward. I'll speak for our organization. Our physicians are super happy to be doing telephone consults and video consults with people. And when I speak to my colleagues across Canada, they all are doing this. So remote care is actually very effective for assessing what you need. If individual fertility clinic labs are closed, then life labs and other labs around are still all open. If it's actually mission critical for you to know a progesterone level, that can still be done. If you need access to progesterone, a physician can still write a prescription. You can still pick it up from a pharmacy. These services all exist. It's just a matter of you contacting your local clinic. They will still be there and able to provide that direction for you.
Great. Do you anticipate initial testing to resume soon? For example, saline ultrasound and HSG?
Yeah, good. It's a great question. So those are two different tests that require some consumption of PPE. You know, people wearing masks and gloves. It definitely requires people to be breaking social distancing norms. We're doing procedures. There'll often be a technician present, a patient, a staff person. It's a perfect question of exactly what fertility clinics are being asked to wrestle with right now. The CFAS, Alex and I have been bringing that organization up a lot, are working right now on guidelines for clinics to be able to provide services again while still maintaining best practices. Alex, do you foresee anything in the lab side that is going to materially change?
I don't think so. I think, as I mentioned, we already operate under all the same procedures that sounds like will be put out by whether it's CFAS or whatever governing body is. So all the equipment, we already wear it. Labs are a very, very clean environment. So I don't really think things are going to change all that much for us.
You know, Alex, you said whatever governing body. That is the truth for medicine, isn't it? Like, I'm just thinking of the number of governing bodies we have. So as CFAS and SRM, those are significant. We talk about them. They're not regulatory, actually. Look at all the other bodies that we have. We have the Accreditation Canada. It's not regulatory, but we definitely follow those. There's CAP, which you guys do. There's the college that I follow. Public health, right? And then national guidelines. So it's because of all those because all those things are in place, it's actually going to be relatively straightforward for fertility. I think it's going to be relatively straightforward for clinics to know what it is that is expected of them to maintain a healthy experience for patients going forwards. This was a long way of trying to answer a question about, are we going to be able to do sonograms histograms again? And the answer is yes. And I think those are going to happen again at about the same time as we all choose to reopen services.
I think it sounds like, Tom, just kind of highlighting your points too. It sounds like sort of PPE and testing for any team, any healthcare related industry that will start opening up during these times. And the virus is not going anywhere. In order to operate safely, you have to have those two measures in place to whichever extent you're able to do, right? Whether you have what PPE you have available, whether testing is available readily for fertility clinics or not, or just screening for temperature and other symptoms, etc. So those two things really will be key in moving forward.
I agree.
Another question just came in terms of, so if the clinics are ideally going to be opening up, whatever that looks like in the next couple of weeks, what about things like elective surgery that support fertility, like removal of polyps or, you know what I mean?
So we've been talking about the two reasons to close. One is sort of, public health, and the other is access to PPE. And it's really through public health that elective procedures have been asked to be put on pause, and that's really what drove fertility treatments. I would argue that it's highly likely that fertility clinics in the main will not be opening up until other elective services are also being able to be provided through the hospital. I suspect that the two will be coming awfully close to one another. The circumstances that will allow for fertility clinics to open up will be the same circumstances that will be allowing for elective procedures to occur within fertility and beyond fertility.
Great. A lot of the things you're saying, obviously you practice medicine in Ontario. You're in touch with colleagues across the country. So what you're saying, is that kind of in line with what you're hearing in other provinces as well?
Yeah. So it's just each province has, as we tried to rattle off, there's a number of different regulatory agencies, and there will be some local twists that will actually have impact on access to care for patients. So my understanding, for example, is that access to care is more restricted in Alberta at the moment at a college level than it would be in British Columbia, for example. it happens that Ontario has, one of the largest populations, and of course, Ontario and Quebec have suffered more through COVID. I would suggest that by the time Ontario and Quebec feel that they're in a position to reopen their clinics, that other clinics across the country will similarly be able to find themselves opening quite quickly after that. It's not to say that everyone's aligned under exactly the same umbrella. It's not that, but the circumstances that would allow us in Toronto to open, one would expect, would allow the clinic in Winnipeg to open, for example.
Okay. So natural conception is kind of what some people are thinking about just because the timelines are unclear. What are your tips what are your top 5 tips for conceiving naturally?
5 tips?
5. Exactly 5.
I think that the number one thing is to be kind to yourself. There's been some really interesting things about sexual health in the media and other sources recently. Let's be honest, this has been an extremely stressful time for all of us. I've actually found it quite upsetting at the beginning of this when people were making jokes about the baby boom that's going to come in 9 months from now. There won't be. There's going to be. It's getting locked at home because you're caught in the eye of a storm, maybe for a weekend. This is quite different. This is affecting all of our lives, all aspects of our lives, all aspects of our health and economic lives for ourselves and our loved ones. You please forgive yourself if you desperately want a family and you're struggling sexually with your partner. It's normal at the moment. So my first tip would be just to be kind to yourself. Secondly, if you're being kind to yourself and you're going to have intercourse anyways, then and you want to have a baby and you're feeling comfortable getting pregnant in the current environment, then it's all about time.
That's a lot of caveats.
It is. It's not for everybody, but for some people, they'll be like, "Yeah, no, I'm in. We're doing this." And so then it's all about timing. And so there's been lots of tips and tricks throughout the years of different ways that people can do timing right for themselves at home. I strongly believe in home LH detection kits. So is it like a branded one is Clear Blue? Is that the Clear Plan? I'm sorry, I don't know. Whatever. I'm not a super strong proponent of one brand over the other. I'm not a big proponent of the more expensive ones that are measuring more than one hormone. I like the ones that are just measuring LH. And if you haven't done this before, buy a branded one, but also get a cheapy no-name brand, because they might both work just as well for you. And if you're fortunate, and most women are, able to detect an LH surge just prior to ovulation. That's what's so good about this. If you're peeing on a stick in the morning and your LH hormone jumps up, what that tells you is you're going to ovulate. You haven't ovulated yet, but you're going to in the next, depending on where you're at, 12 to 36 hours. In other words, have sex sometime that day. In the morning, if that's you guys. In the middle of the day, if that's your current lifestyle. At night, if that's when that's the only chance that you get. It's not a big panic. It's not a big rush, but that's the day. And if you want to have intercourse the next day after that, 2 days in a row, perfectly acceptable. Another way that people are doing this, of course, is using apps. That's a calendar-based system. So the app will tell you when you should. In those scenarios, people will often have intercourse every second day because it's a little less precise. So if you don't really know exactly when you're ovulating, then every second day might be better rather than 2 days in a row. Exactly the same pregnancy rates between those two approaches. So peeing on the stick, using a calendar, it's never been proven that one is better than the other. My advice for one cycle, do both. As I said, buy the branded one, do the cheap one, use an app like Clue or whichever one that you would prefer, and figure out which of those works best for you. Unfortunately, there are some people where timing won't be all that effective. I'll give you an example of a diagnosis. Polycystic ovary, by definition, those women don't really know when they're going to ovulate, and none of those techniques work particularly well. That's an argument in favor of fertility clinics being open again. As I said, hopefully we're talking about weeks, not months, but not today.
I think that was like 3, but that's okay. I'll forgive you.
Okay, fine. I'll take 3. All right, how about 2 more? Don't let position, position doesn't matter at all. Orgasms are great for intimacy, but doesn't change anything. Well, it does on the man's side, but doesn't change anything on the woman's side for whether or not Charlotte should be able to achieve pregnancy. What else can I say? What else would be important to know? Vidya, what would you suggest?
Something about pineapple. Do we need to eat pineapples?
No. Oh, no. Right. So one of the great dilemmas of the internet is, and we've all done it, when we all drop down the rabbit hole, you know you're going to end up in a particularly dark corner where you're meant to eat pineapple cores, not the yummy part of the pineapple, as if that's going to improve implantation. It doesn't do anything. There's bee pollen, and there's just some unfortunate pressures that people will put themselves under. That's why at the beginning of this, I strongly suggested working with a naturopath or other caregiver that you trust to help provide you some direction on this. Let them have done the deep internet search for you so that they're able to provide you advice that actually is applicable to your situation. I don't know anyone who should only be eating pineapple cores.
It's like the worst part of the pineapple. It's so bad.
It's also, well, whatever. There's so many levels of absurd to that one. But the underlying truth is people are just trying everything, right? And especially in these moments when we don't have access to in-person care, people are really just trying. And I'm sympathetic to that, but I hope that they can find caregivers online by phone, by video conference that will help them negotiate those things.
Absolutely.
Can I just add one more, guys, to your,
Sure.
Can I make it 6? I just wanted to say that there's been a lot of just people gathering and talking about hope, and you hear all these people putting signs up on their windows and so on, trying to instill confidence and positivity. I think it's important for everyone who's trying at home to know that there is hope, and if this not work for you at home, we will be there for you eventually. Like Tom said, whether it's weeks, hopefully that if it doesn't work, then we will be there, and there is hope, and we'll help you once the time's right.
Thank you, Alex.
Yeah.
I would just suggest in the next couple of weeks, and particularly during CIAW, this is a time to, get reliable information about the journey and things that can help you in it, so that when you do get back to treatments, you can go back more informed than you were before. Okay, I think that's it. I'm getting some funny tips and tricks here. I'm not going to repeat them. But thank you so much, Dr. Hannam and Alex. We really appreciate you taking the time to talk to the fertility community and give such insightful information that will help people get through the next couple of weeks. As I mentioned,
thank you so much for what you're doing, because I know you need to say this at the end, and I agree with what you're about to say. Anything that you can do to keep more people being able to do these things. Your representation of patients is extraordinary. I think the reach that your organization has is far more profound than the number of volunteers who are able to provide time. It's really because of people like yourself that this is all possible. So thank you for doing this work for so many other people out there who are struggling and might otherwise feel alone. I'm most appreciative.
Thank you. That's great. That's like that should be an ad for Fertility Matters. So for everyone out there, if you enjoyed today, I know I did, and if you want to keep seeing great content from professionals in the field, please, if you can, visit the Fertility Matters Facebook page, click any small donation will help. And please check out the events calendar, because this is the first of daily Facebook Lives with other professionals in the field, not just REs and lab directors, but counselors and financial experts and lots of people to help you attack this journey from a holistic perspective. Okay, thanks guys. I don't know how to stop this, so Carolyn, if you're there, if you could sign us off, that would be great.
I'll walk off screen.
Yeah.
Everybody walk away.
Thanks, everyone. Take care.
Thank you, everybody.
Thank you. Thank you.
Thanks, everyone.